class.
Thank you, madam.
Now we have next Dr. TITIYAL sir. He'll be talking about the posterior polar cataracts.
Good afternoon, friends. I think in continuation of previous sessions also, the talks are, repeated so that people take away some important tips and different areas. Posterior polar cataract, you all know, is challenging sometimes. And we talked about surgeries, but it's very important to really assess your patients carefully and examine them in terms of integrity of posterior capsule. Selective examination sometimes is feasible to really take account of a nucleus hardness. Apart from the disc which you are seeing, the nucleus hardness is also an important factor for a posterior capsule which may get damaged during the surgery as such. The next important part is the anti-segment OCT, which can actually give you a delineation. I just remember a question from Dr. KPS Malik. Not all cases of said or diagnosed posterior polar may not be posterior polar, but it can be differentiated by various ways. One is anti-segment assessment by ASOCT, which can delineate the posterior capsule, the disc, and you can actually know which are those cases will have maybe the loose capsule or a defect in these cases. So surgery-wise, you all are aware that surgery has to be thought simply and done simply by making the rhexis size, which may be around 4.5 to 5 millimeter in these cases. And subsequently, if posterior capsule get damaged, you can put the lens on the anterior rhexis and get capture. That situation normally doesn't arise in all cases, but this you can see a classical posterior polar cataract, as we know that onion peel type of appearance or a bullseye pattern which is seen here. So always do a rhexis which is complete and make sure you avoid hydrodissection in most cases and do only delineation which will help you to actually take out the endonucleus first and then take out the epinucleus subsequently as per the requirement. So if you see here, I'm doing a hydrodelineation here. Just doing a delineation, one core, then we'll have a second core happening, which will strengthen the initial hydrodelineation. And subsequently, you can do a layer by layer or chip and flip technique in these softer nucleus. So one way of handling the posterior polar nucleus is doing a chip and flip. I'm doing a softening or a taking over the central area, debulking the central core, keeping your parameter absolutely normal, no phaco being used. It's just a vacuum aspiration of a cortex. Just see here, no phaco is being used here. Little torsional phaco is coming now. Just flip the entire area and make sure you don't disrupt the cushion which you have created by delineation of epicortex. That is our teaching for all posterior polar cataracts. Now, just rotate the endonucleus, take out this piece, and you can see the entire thing has come out. Now you can take out epicortex layer by layer also. This is the inner epicortical layer. Then you'll go to periphery. And by the time there will be a fluid going into the between the posterior capsule and the epicortical area, which will make sure the capsule remains intact till your surgery, end of surgery. So this is how it is completed, and you can take out the final cortex and complete the surgery and implant the IOL in these cases. So this is what we have recently described in a posterior polar cataract. You all have seen this a central disc defect coming up after you complete the nucleus emulsification or you remove epicortex in these cases. So this we named as a intraoperative posterior polar cortical disc defect sign, which is normally seen in a large number of cases. Around 90% cases you'll see this disc. Around all these cases, whenever you have a disc coming up, you are quite safe that you won't have a PCR in these cases. This gives a false pseudo impression that PC may be defect in these cases. You can see after the completion of a epinuclear cushion, you can see in 90% of cases. After a cortex removal, 8% of cases. After nucleus emulsification, you see around 2% of cases. So these are the highest risk cases because they have a defect right from the beginning. Their addition will be much more. So if you don't see this cortical disc defect, That means your entire complex is attached or adherent to the posterior capsule. So there are higher chances of capsular tear happening in these cases, which may be around 40% cases might have a tear opening up. We see 9 cases, we didn't see of that 2% had a tear in the posterior capsule. So this sign is a safeguard for our people to know that they won't have defect in these cases. So this is a nucleotomy being done. I'll just go to the defect in these cases. You can see as soon as I lift this quarter, you can see the defect is seen. So this might give you a jittery feeling that posterior capsule may be defective. It's not that. It is clear posterior capsule there. You can see the OCT microscope. You can see the posterior capsule also. So this defect is a safe sign for us. Other way of assessment is intra-op OCT also that can delineate the various types of posterior polar cataract. Type 1 may be a subcapsular type of cataract where you can delineate the entire length of posterior capsule right from a periphery to center. Type 2, you can't delineate the capsule in a central area. So this may be a typical posterior polar cataract. Type 3, right from the periphery to center, you can't see posterior capsule. So these cases will have a higher chance of defect happening as such in these cases. The surgery is simpler. So this is one case. If you see this particular case, we have a central disc here and a radiating spokes of this disc, which is and central hollow. So that might indicate the posterior capsule may be defective. So if you see the OCT in the microscope, you can see this hollow defect or a bag type of thing seen in the posterior capsule. So this capsule is absolutely weak or maybe a little fibrotic changes happening. The capsulotomy or a capsule access should be done after staining. I'm aiming for around 5 millimeter or a 4.5 millimeter access in this particular case here. And make sure, take time on doing a capsular access in all difficult cases, including a posterior polar. Make it central and circular so that at least you have a safeguarding the IOL part as such. You may have to shift from in the bag lens to in the sulcus lens, but can be done. So I'm doing a hydro delineation. You can see the bag is still maintained, and I have a delineation. You can say channels are seen here. So this indicates my delineation complete now, and I can do. This was a 25-year-old young person, so congenital posterior polar cataract as such. And the core was freely mobile. So I could do a emulsification. Again, I'm doing a vacuum hold and chopping without using the torsional power of a phaco machine, because it is important because normally they are soft in the periphery and you might go through and through sometimes. So whenever you do a posterior polar cataract, play in the center, don't reach to periphery, otherwise you'll disrupt the nucleus core as well as the epicortical cushion also, and posterior capsule will get exposed. The entire disc is being removed now. The disc is also attached to this. So you will see this particular case, the thin fibrotic membrane is still intact and it is hanging downwards. So I'm doing a cortex removal. Once I remove the cortex, shift to a management of posterior capsule in this particular case. So I'll use a hybrid technique of aspiration. One side aspiration cannula and I'm maintaining the handpiece here. I thought I'll take out this bag because you can see a very loose bag here. And there's a small tear which come up. So I'm injecting dispersive viscoelastic to maintain the anterior chamber and the posterior capsule. And inject the IOL now. Once you have a defect, you can see a small defect here. Make sure you inject the IOL not into the bag, outside the bag, so that you can manipulate the haptic. So I'm enlarging my 2.2 to around 2.8 so that the IOL can be injected onto the surface. And gently I'll tuck the haptics in the bag so that capsule is not disrupted. So this is the Technis eye-hand lens, which has been injected now over the iris surface. And subsequently, I'll manipulate the haptic into the bag with a bimanual technique. So whenever you have a PC defect, don't try to inject in the bag, otherwise the defect will enlarge and you'll have a large defect and the lens will not be properly placed. So I'm injecting the haptic here, and I'll have a bimanual technique to get this haptic back. So you can see this is a small tear here, as well as this loose fibrotic bag. In all congenital posterior polar cataract, you'll have some sort of disturbance in the anterior chamber, anterior vitreous area also. So I'm doing a vitrector assisted opening of anterior capsule. So you can see this entire fibrotic membrane eaten out and it will get attached to the tear which was there. So sometimes it's very difficult to do a rhexis in these thin fibrotic membrane-like a structure, which will become a too larger rhexis. So you can see a very nice opening I have created, and that's the end of surgery. You can see the peripheral opaque area also, which is fibrotic. Lens is stable, and you can see the posterior capsular opening also. So this is the one message for managing the weak capsule or a open capsule in a posterior polar cataracts. Other area maybe femtosecond laser. Dr. Abhay Basavalda talked about this. So this technique, we create the 3 safety rings, and you have a 6 chop. So it gives each segment as a block here: primary block, secondary block, tertiary block, then epicortical cushion. And they can be taken out layer by layer. You can say piece by piece. So you maintain the entire epicortical cushion till the end, and you don't have to do hydro delineation at all in these cases because the air bubble delineation happens in these cases. Just to summarize, which are those cases where you can do hydrodissection? Because classically we say only delineation. But if you can delineate the entire posterior capsule with your anti-segment OCT or IOCT microscope, you can do a hydrodissection. Surgery becomes simpler, faster, and less complication. But if you have a cataract, the posterior polar disc is larger than 4 millimeter, nucleus is harder, and the anti-segment OCT cannot assess the posterior pole clearly, then you should not do hydrodissection at all. So if you go by this, then you have a very less chances of a complication happening in these cases. If you have access to femtosecond laser, always beneficial in posterior polar cataracts to really minimize the complication happening. In fact, in our series of more than 100 cases, I think we did not have PC rupture happening in these cases because of safety of epicortical cushion. The posterior polar cataract can be managed very effectively, and you can come out with a very, very good results in these cases, even in those cases where your posterior capsule is open. Thank you for your kind listening.
Wonderful, illuminating talk as always, sir, and great pleasure to see your presentations at all times. While we take questions, I just request Dr. Gaurav Luthra, sir, to please come forward and set up for his next talk. Sir, you showed some videos where there was a large PPC with a significant amount of nuclear sclerosis as well. So in those situations where we really can't do a good hydro and cannot rotate the nucleus, what would be the techniques that you'd follow to remove the nucleus safely?
Yeah, thank you, Shreyas. In fact, that is another talk in another course where only nucleus management is talked about tomorrow morning. But yes, it's always a challenge to do a proper appropriate nucleotomy in cases where you have not done hydrodissection. And sometimes delineation is also not complete. The nucleus is in bulk in the bag. In that, what technique, in fact, this time the video is also accepted in academy also. We make a central trench, and that is around 1.5 to 2 diameter of your phaco handpiece. Make an initial chop, then take a pie of a piece from a side. So this gives a space for fluid to get in, and the nucleus will get delineated better if you have done an earlier incomplete hydro delineation. So this will safeguard, and if possible, if the nucleus still doesn't move, you can take another pie from the other side so that you have a larger area of uh, vacuum where the fluid will seep in. And then subsequently, you can just nudge the nucleus to center, and that falls back to center, and you can complete the nucleotomy. And subsequently, you can just do a epicortical aspiration from periphery, leave it to center, and take out the entire bulk of epinucleus and cortex complex towards the end. And this holds true that the pie-shaped chunk of nucleus removal holds true for a softer nucleus also. Sometimes they are also difficult to take out without disrupting the epinucleus. There also you have to make a fluid cushion, take out the piece by piece.
Wonderful explanation, sir. It was almost like we were watching the video while you were explaining. The other quick question I had was, in case where the PC is deficient and other things, very often in PPC we encounter a vertical split, sir. So would you encourage trying to convert to a PPC or PCC, or would you just say that we put a IOL in the sulcus with a good optic capture?
No, Shreyas, you are absolutely correct. Sometimes you are very lucky The opening, is normally elliptical and it remains the center. If the size is less than 2 millimeter, the opening, you can make a PCC out of that and complete that circular area. But if it goes to periphery beyond your capsular access margin, then it's very difficult to make a posterior capsular access out of that. In that situation, I would suggest just take the, change the lens. If you have the inventory for a 3-piece lens available, get the lens in the sulcus and get it captured. But most often, sometimes these patients may have a toric implantation or they may have a multifocal implantation. If the toric lens has a absolutely right angle to the tear, you can still manage that. But if it's the same axis, you can't put toric lens there at all. For a multifocal also, sometimes you can manage. As I showed in this video, you fill the bag with a dispersive viscoelastic, which is normally viscoat, and get the lens to open on the surface. And before you tuck the haptics, get the lens rotated just right angle to the tear. Then just tuck the haptics inside the bag, and you can still have a nicely stable IOL as such. But most difficult is the axis of implantation and axis of tear is similar. Then it's very difficult to manage.
So given a choice, would you prefer femto laser or MICS for a polar cataract?
No. Given a choice, if patient can afford, I will always do a femtosecond laser in these cases, because it really gives a benefit of a nice capsular axis, well designed, and gives a femto delineation, which is a major advantage in these cases. Incision may not be important, but these two are very, very important. Opportunity, yes, always do femtosecond.
Only unfortunate thing is that those rings are available only on LensX,
Yeah,
not on other platforms.
That's true. Because I have done 1 or 2 cases in other you can see technologies. There you can't see what has happened. In fact, in one of the live surgeries, I was just asked, we have done femto, you do the phaco part. I never realized there was a posterior polar cataract. So I did all hydro procedure and there was a large open posterior capsule in those cases. So that gives a very good idea. Femtosecond laser also has a OCT attachment. So you should always see the OCT picture on femtosecond also, and that will give you a type of posterior polar cataract, and you can manage very effectively in these cases. That's the advantage of femtosecond device.
Thank you so much.